Good afternoon, everyone. Welcome to Medical Grand Reps. Before we begin, I'd like to make a brief land acknowledgement. McGill University is on land which has long served as a site of meeting and exchange amongst Indigenous peoples. We acknowledge and thank the diverse Indigenous peoples whose presence marks this territory on which we now gather. Just a brief reminder to leave your questions till the end. I ask that you please enter them in the chat. And please answer the brief survey that will be sent to you immediately after the presentation. It will let us know that you are present here today. And finally, I'd like to invite Dr. William Folks, the Chief of the Division of Genetics, Medical Genetics, to introduce our speaker today. Dr. Folks.
Thank you, Nadia. Okay, well, it gives me a pleasure to ask Tania Cruz Marino to come and talk here. So those of you who don't know Tania, she came to the division in 2023, following a circuitous route from we started off in Cuba, where she got her medical degree and then a medical residency and a Ph.D. from the Havana Superior Institute. And she has a certificate in medical genetics from the Collège of Medical Genetics of Quebec, and was in Saguenay actually from 2015. We're the only medical geneticist in Saguenay and still working there, I think, sometimes, occasionally, which is great for them. And joined us in 2023 to focus on cancer genetics. And I'll let you take it away, Tania.
Thank you very much for the introduction, and thank you for having me today. So we are going to this lecture that is called Through Naked Skin, from Common Cutaneous Lesions to Hereditary Cancer Predisposition Syndromes. I have no conflicts of interest to disclose, and I gratefully acknowledge that I am working on the traditional territory of the Kanaka. Through this lecture, we are going to see some of the CAMNES competencies, like medical expert, scholar, collaborator, and communicator. And at the end of the lecture, the participants will be able to describe cancer predisposition syndromes that present with characteristic skin features, summarize the referral criteria to medical genetics or to the oncogenodermatology clinic, and explain the recurrent risk for family members of affected individuals with some of these conditions. To start with, we will do a quiz, and please don't be shy. It's just for having a capture of your first impression on these questions. And at the end of the lecture, we will review together again the questions and the answers, because you are not seeing the answers now. So you will be able to see how different your view could be on these questions from now to the end. Okay? So I will go through the questions, and then with the help of Sylvia, you will have the quiz on your computers, and you will be able to vote for those who are online. And for those who are here, you can do it through the phone, or you can raise your hands as you want. So question 1, actor Hugh Jackman developed the first vasocellular carcinoma, or VCC, at the age of 45. 3 years later, he had already developed 6 VCCs. And he would like to understand what is the risk for his family members. So to accurately estimate this risk, which of the following questions would you like to ask him? Number 1, when you spend time at the beach or in the pool, do your hands or your feet look like this? And you have the picture here on the lower corner of the screen. Do regular baseball cups fit you properly? Have you had a cyst growth near the base of a tooth? Or all of the above questions. Choose your answer, and then when the pool is out, you can just mark the one you prefer, okay? Question number 2. A 40-year-old male is diagnosed with malignant melanoma. Which aspects of the family history would you be considering to refer this person to medical genetics or the oncogenodermatology clinic? Pancreatic cancer, atypical nevi, multiple individuals with melanoma in the family, or all of the above? Question 3. A 30-year-old female presents with a history of irregular and heavy menstrual bleeding. Pelvic ultrasound reveals multiple uterine fibroids. Family history is positive for paternal nephrectomy at age 36. On physical exam, you observe these skin lesions, one of which the patient report has been biopsy and it was benign. So what would you see in this person is at risk for? Endometrial cancer, skin cancer, kidney cancer, or none of those? And finally, you have this 5-year-old child who was born to consanguineous parents. They are first cousins. He has a family history notable for colorectal cancer at age 45 in his paternal grandfather and endometrial cancer at 48 in his maternal grandmother, and they are siblings. So on exam, you know, these skin findings that you see here in the picture. Which would be your primary concerns? Is this neurofibromatosis type 1? Is this neurofibromatosis type 2 or Noonan syndrome or constitutional mismatch repair deficient syndrome? Now you can vote.
Maybe, what's the winner in question one? Well, question one is, question number 4. Answer 4, okay. And, question 2 is answer number 4. Is 61%. And 39% question number 3, answer 3, taking answer. And question number 4, 35% constitutional.
Okay, so let me just repeat for everyone. So for question number 1, most people say answer 4. For question number 2, answer 4. For question number 3, answer 3. And for question number 4, answer 4. So it seems you are very well prepared, so you know most of the answers, but let's go together and review all these topics. So to start with, as you all know, the skin is the largest organ in our body, and it will cover all our body, protecting us from germs, from heating, and also from ultraviolet light exposure that comes from the sun. So it's very important to always be aware of performing a complete physical exam of the skin that will go from head to toes, especially because sometimes we will find small windows in the skin that will suggest we are in the presence of a cancer predisposition syndrome. We have common skin manifestations or conditions that not only doctors, but anyone in the common population will be aware of, like basal cell carcinomas, melanoma are terms that everyone is familiar with. In the same way, cutaneous uterine fibroids or café au lait spots are also well known by many people. On the contrary, there are some genetic conditions that are very rare, and there is a link between some of these common manifestations and these rare conditions. So this is what we are going to be discussing today, how we made the bridge between what is rare in genetics, and these are individuals that are initially within the pool of the common conditions that we find in the general population. Australia is considered the skin cancer capital of the world. And why is that? It's because every year around 1 million people will be treated for some form of skin cancer. 2 out of 3 Australians will develop cancer of the skin at some point before the age of 70 years. You probably know actor Hugh Jackman, who has been a great work making people aware of the risk that sun exposure means to people at risk for vasocellular carcinomas, as it's not by chance he comes from Australia. So if basal cell carcinoma are so frequent in the population, which are the individuals who are at risk for a genetic condition that we will know as Gorlin syndrome? So let's start by talking a bit about what vasocellular carcinoma is. So this is the most common form of skin cancer and will affect around 80 to 90% of all the people who have skin cancer. This is a kind of lesion that will start here at the basal cells and that is locally destructive, but rarely will metastasize. There are many risk factors that will be related with the origin of vasocellular carcinomas, the most important being chronic sun exposure. That is why most of the lesions will always be located on the scalp or the face or the neck. There are other multiple risk factors, and as you can see, inherited syndromes are down in the list. Is because only a few people with vasocellular carcinoma are really affected by a genetic condition. The clinical aspect of vasocellular carcinomas is very different in different patients. You can have pearly white color or skin color bumps in the skin. You can have scaly lesions. You can have growth or scaly lesions on the skin. You can also have waxy scarlet lesions. But in general, most patients will refer to them as a change in the skin like a growth or a sore that never seems to heal, related with the long and slow evolution these lesions tend to have. In Canada, over 80,000 people will be diagnosed every year with BCCs. So 1 in 8 Canadians will develop BCCs. That means around 5 million people in Canada are going to be affected by this condition, giving you, as general population, a risk of 12.5% of developing a BCC. On the contrary, Gorlin syndrome is considered a rare genetic condition. The estimated prevalence is 1 in 30,000. If this is true in Canada, then are we having around 1,300 individuals affected with Gorlin syndrome in Canada? So when should we refer individuals with BCC to genetic services? For Gorlin syndrome, we have clinical criteria, and they are major or minor criteria. The first criteria in the major group would be the multiple basal cell carcinomas. So these individuals, differently from the general population, do not develop one late in time. They will develop multiple BCCs, and many of them will have more than 5 in a lifetime, and especially the first one usually can present before the age of 30, so has a very early onset. They will have these lesions that you can see here that we call palmoplantar pits. And these lesions are more evident when people keep the hands or the feet in water for some time. So we can ask the patients, when you go to the pool or you are at the beach, is this something that you see on your hands and feet? Another major criteria would be the development of jaw keratosis, and this is a common reference now from dentists to our services. So individuals who have jaw keratosis are referred to genetics to rule out this condition because it's a major criteria. Lamillar calcification of the falx cerebri is also common, and of course, a positive family history. In the minor criteria, the first one that we should never forget is macrocephaly. So this is why we can ask anyone, how does it go with cups? If you have a baseball cup, does it fit properly? It's because macrocephaly sometimes is being clinically diagnosed by your doctor, but sometimes it runs in families and people are not even aware they are affected by macrocephaly. There are other minor criteria that are also present in these individuals, like cleft lip or palate, preaxial or postaxial polydactyly, vertebral or rib anomalies, and childhood medulloblastomas, as well as lymphomesenteric sclerosis, ovarian cardiac fibromas, and ocular anomalies. So to establish the clinical diagnosis, you need 2 major criteria and 1 minor or 1 major and 3 minor criteria. This is a condition that shows a very important inter and intrafamilial variability, that meaning not everyone in the family will show the same clinical features, and even from one family to another, we see a different expression. There are 2 genes that are mainly implicated in the causation of this disease, and these are PTCH1 and SUFU. Also, we observe variability related to what is the gene that the person is having the variant. So if you are affected with a variant in the PTCH1 gene, you have a high probability, over 90%, of presenting macrocephaly, basal cell carcinomas, and jaw keratosis. But it's very unlikely that you will have medulloblastoma, although 2% of individuals can have it. On the contrary, if the gene where you carry your pathogenic variant is SUFU, there is almost never seen the presence of jaw keratosis. Macrocephaly is present in 60% of the individuals, but the highest risk is for medulloblastomas that will be present in around 30% of these individuals. So it's an autosomal dominant condition. That means every first-degree relative will be at 50% chances of inheriting the pathogenic variant. And we see a complete penetrance for some of the clinical manifestation of PTCH1, which is more reduced for SUFU. And there is a third gene that I just want to mention because you can find it in some reports, that is called PTCH2, but only 2 families have been reported with variants in this gene. And at present, these findings have not been replicated in other families. So it's not completely accepted as a gene that is able to produce Gorlin syndrome. How do we assess the recurrent risk? What can we tell individuals about their own risk or the risk for their relatives? So if you come from the general population, your chances of developing a BCC is around 12.5%. But if you have a first-degree relative, that means one of your parents, one sibling, or one of your children who is already affected by BCCs, your chances will be double. So your chances will increase to 19 to 25%. And if in the family we see two individuals who already have vasocellular, then we are talking about the familial form of vasocellular carcinomas. Having a familial form doesn't still mean that this is hereditary. We are going to talk about the hereditary form in Gorlin syndrome when we identify pathogenic variants in PTCH1 or SUFU genes. And in this case, unfortunately, the chances of developing vasocellular carcinomas are over 90%. So in brief, the most common presentation of vasocellular carcinomas in the population is the sporadic form. This will present mainly as simple lesions and over the age of 50. When you have two or more people affected in the family, then you are talking about a family form of vasocellular carcinomas. But when you are talking about Gorlin syndrome, this is really the hereditary form with a very, very high risk to develop not only vasocellular, but the other clinical features of the disease, and with an early age at onset, even during childhood or adolescence. So I have invited to close the chapter on vasocellular this painter from Dodge from the 17th century. So this is Rembrandt. If we look here, Rembrandt is known for having performed probably the largest series of self-portraits in the art history. So he made around 100 self-portraits. So what you see here are 4 self-portraits that he made with 5 years of difference. And if we take a closer look to the nose, there are pearly whitish lesions. So we cannot have a way to validate these were vasocellular carcinomas. But what is interesting is if this was vasocellular carcinoma, then Rembrandt was able to capture the slow progression and the low aggressivity of this disease. So we can say then that before dermoscopy, maybe there was Rembrandt. So let's go to the second disease that we want to discuss today. Melanomas are very frequent also in the common population. And there is a new condition that is known as familial malignant melanoma. So which are the people with familial malignant melanoma that are inside the pool of people with sporadic melanomas? Let's try to get to that. So melanomas will develop from these cells that are here that, as you know, are called melanocytes. And they are not as frequent as vasocellular. They only represent 1% of all these forms of skin cancer. However, they are the most serious and dangerous form of skin cancer and responsible for the majority of skin cancer-related death. So it's very important to know about this condition. There are risk factors that increase your chances to develop melanoma. Again, sun and indoor tanning is going to be the most important factor, but in this case, there is also another manifestation that we have to take into account, which is the presence of multiple atypical nevi. If you have more than 50 nevi in your body, then this should raise suspicion and we have to do a closer observation. There are other risk factors that you can see here, but again, inherited syndromes that can cause skin cancer represent only a minority of this group. From the clinical point of view, for screening of melanoma, remember there is the ABCDE rule, right? So A for asymmetry, so these lesions should be asymmetric. B for border, the borders are going to be jagged or also irregular. C for color, so you can have more than one color inside the melanoma. D for diameter, they usually measure more than 6 millimeters. And E for evolution, since these lesions suddenly can start growing or changing in size or in shape. Only in 2025, that means last year, it was estimated that in Canada we would have 10,800 new diagnoses of melanomas. And around 1,250 of these individuals were supposed to die last year. So around 10% of any individual who is diagnosed with melanoma will have at least a first-degree relative with melanoma. If we make maps, that could mean that maybe in Canada, only last year, we had 1,080 individuals who had a positive family history. So is that enough to think these individuals have familial malignant melanoma, or do we need other criteria? So the clinical diagnosis of familial malignant melanoma will take into account what is the geographic area where these individuals come from and the incidence of melanoma in the geographic area. So we have the rule of 2, the rule of 3, and the rule of 4. In the case of the rule of 2, it's going to be applied for those countries where the incidence of melanoma is considered low or moderate. An example is Italy. The rule of three is going to apply for those countries where we have moderate to high incidence of melanoma, and Canada is in this group together with the States. Finally, the rule of four is going to be applied to those areas where the incidence is very high, and the best example that we are aware of is Australia, right? So what is the rule of two? We are going to consider this condition when the individual has developed two melanomas. The individual has one melanoma, but has at least one first or second degree relative who has developed either melanomas or pancreas cancer. And you will see later why pancreas cancer is so relevant in this diagnosis. In the rule of three, the individual can have three melanomas. And remember, these melanomas can also be synchronous or metachronous, so it doesn't have to happen at the same time. Or the individual can have one melanoma and have relatives, at least two or more, who had melanomas or pancreas cancer. And so on. The rule of four is one individual with four melanomas or one melanoma in the individual and at least three relatives who have had either melanomas or pancreas cancer. In our clinic of oncogenedermatology, we also consider other criteria because I'm going to show you now 5 criteria that you can use to send referrals. However, the first two you will see that are related to the rule of three, is the one that we should apply in Canada. So the first one says, if you have a personal history of 3 or more malignant melanomas, or if you have multiple atypical nevi, more than 50, then we would be very happy to see you and make surveillance. But there are contexts that are atypical that we should also consider. For example, one individual who has darker skin, who we know is more protected from ultraviolet light and is developing melanomas should also be taken seriously, as well as individuals who are never exposed to light, or solar light, and again, they are developing melanoma. So these are cases that also should be referred. The second criteria also relates to the rule of three, is when you have a personal history of malignant melanoma and you have 2 or more relatives who have melanoma or pancreas cancer. But the other 3 criteria are more specific and should also be taken into account. For example, if you have malignant melanoma, but you are under 40, so you have a very early onset of the manifestation, and you have at least one first or second degree relative, especially if you are under 18 years of age, please refer these patients because they could have familial malignant melanoma. Number 4, a personal history of uveal melanoma. We know there are 2 genes, BAPA1 and MBD4, who can predispose us for uveal melanomas, which is very rare. So all individuals with uveal melanomas should be seen in genetics. And finally, a personal history of malignant melanoma and family history of other cancers, mainly pancreatic cancer, kidney, brain mesotheliomas, breast or skin cancer. So around 20 genes have been associated with this form of familial malignant melanoma. These genes can have a high penetrance, lower penetrance, or intermediate penetrance. I leave for you here some of the most important examples. And let's start with CDKN2A. This is a gene that is very important because it's responsible of 20 or 40% of the cases with familial malignant melanomas. And interestingly, individuals who carry this gene will develop either melanomas or pancreatic cancers, and in some cases, brain tumor. So this is why you see that pancreas cancer is always in the rule of 2, 3, and 4, is because many of these familial cases are due to this gene, and one of the expression of these pathogenic variants will specifically be pancreatic cancer. Other genes that are important to know, CDK4, which apart from melanoma can produce brain cancer. There are a group of genes that are more related with hematologic malignancies that you can see there. And in the intermediate penetrance, MC1R is very important because of the high prevalence of these pathogenic variants, not only in melanoma, but also in non-melanoma skin cancer. Familial malignant melanoma is inherited with an autosomal inheritance pattern also, so the recurrent risk is 50%. And again, we will see reduced penetrance, that meaning not all individuals in the family who carry the pathogenic variant will develop the cancer. And there is variable expressivity, so some individuals will have pancreas cancer, some individuals will have melanomas, or some will have both. So how to assess risk in these cases? If you are an individual from the general population, your chances of developing melanoma in your lifetime is around 2.3%. But if you already have one first-degree relative affected with melanoma, then these chances will duplicate or triplicate, and then your risk will be from 4.5 to 7%. This would be the familial form. So having relatives with melanomas doesn't still mean it's hereditary. To be hereditary, you need to be affected with familial malignant melanoma, where there are multiple genes, as we said before, and in the example of CDKN2A, your chances of developing melanoma will be as high as 76%, and your chances of developing pancreatic cancer go to around 15%. So in brief, there are forms of sporadic melanoma, which are the most common in the population. They usually happen over 50 or 60 years of age, so they have a late onset and are very, very influenced by ultraviolet light exposure. Familial forms, we refer to them when you have 2 or more individuals affected in the population. In this case, risk will duplicate or triplicate, but the highest risk is in those individuals who will carry pathogenic variant in different genes, especially CDKN2A, and the risk will go as high as 70% and is inherited in an autosomal dominant way. So it's very important that we are able to identify early these individuals. So another Rembrandt painting to close this chapter. This is Bathsheba, the hair toilet. This is a painting that has been discussed in many scientific articles because, interestingly, she will show here on the left breast a lesion that some people think this could be just thrombophlebitis of a vein. Some people say, oh, she is affected with breast cancer. But interestingly, she has also a lesion here that is dark, asymmetric with irregular borders. So there are also people saying maybe the painting was seeing someone in front of him with melanoma. He didn't know the diagnosis, but he was able to capture, again, these images. So remember that diseases of the skin are diseases that we can see. So again, it's important to perform this physical exam from head to toe to be able to identify any relevant lesion. Our third disease that we are discussing today are uterine fibroids and in relation with cutaneous fibroids. There is no people in the population that has never heard about that, right? So uterine fibroids are very common. But if I tell you we are going to discuss a condition that is named hereditary leiomyomas and renal cell cancer, maybe you are not as familiar as you are with uterine fibroids. So uterine fibroids are the most common benign pelvic tumor in females, and they usually present after the age of 40. But when we get to the age of 50, around 80% of Black women will have at least one uterine fibroid, and around 70% of white women. The fibroids can be very different. They vary in size and location. Sometimes they are barely noticeable, but sometimes they are large enough to distort the abdomen and produce a prominent abdomen. In the general population, only half of the cases will have more than one fibroid. We call them uterine fibroids, which is the same as uterine leiomyomas, right? So there are different risk factors, again, for developing this condition in the population. These include age. Being older increases your chances, as we explained before. And another important factor here would be the family history, because in families where there are at least 2 females with fibroids, we see that first-degree relatives have an increased chances of developing fibroids that is around 2.2 times higher than the general populations. One more time, inherited syndromes will only represent a minor portion of the people who have uterine fibroids in the population. So if we are saying that 70 to 80% of women will have some uterine fibroid by the age of 50, that means that in Canada, 14 to 16 million women will develop fibroids over their lifetime. So this is a very, very big cohort. So who are the people where we should suspect the genetic disease? This is a genetic condition that in the past we used to say that was very rare. But now the last literature, the most fresh literature refers that the carrier frequency for this disease can be indeed very, very high, as frequent as 1 in 1,000. So if this is true in Canada, we should be having around 40,000 carriers of this disease in Canada, and we are not aware of that in many cases. this disease will have four main characteristics. The first one is uterine fibroids, but these fibroids are very particular and very different to the ones we see in the general population. These are fibroids that present at the younger age, with a mean age of 30 years in comparison with 50 years in the general population. They will be associated with abdominal pain, irregular menses, menorrhagia. They are very, very symptomatic. They can be numerous, large, and they are responsible for a lot of surgical procedures like hysterectomy or myomectomy that will happen also at a very young age, sometimes compromising the fertility of this carrier individual. From the pathological point of view, they have also specific characteristics. They are deficient in fumarate hydratase protein. And pathologists are one of the main colleagues who are referring these cases now to us because they are able to identify not only the FH deficiency, but also these lesions will be positive for S2-succinylcysteine and will have anatomic characteristics that are very particular to them. As an historical reference here, I'm showing you here the uterine fibroids present in a female of 30 years of age. This was an article published in 2016 by Dr. Fox and Dr. Tulandi, and by the time we thought that this was a very, very rare condition in the genetic setting, which now we think is not the case. The second clinical characteristic of this disease are the cutaneous leiomyomas. So as well as you develop uterine leiomyomas, you can also develop leiomyomas on the skin. This will be, as you can see in these pictures, firm or skin color or light brown papules and nodules. And they will be, you can see here on this figure, they can be distributed along the trunk, the extremities, and occasionally on the face and the neck. They can be multiple. Sometimes they are solitary, or they can be segmental, disseminated, and some of them are painful or very sensitive to cold or to touch. Usually, these lesions will be known around the second to fourth decade of life. Some can present early, as in childhood, and they will have a tendency to increase in size and number with age. Because these are rare lesions, when you identify them, this should be a highly suggestive lesion for this disease that we call HLRCC. The third characteristic that is the most important from the cancer point of view is the risk for developing renal cell cancer. These are families where individuals will develop one solitary lesion, but it's a solitary lesion that is highly aggressive and that will metastasize very early. Some individuals can have multifocal or bilateral cancer, but usually it's a very small lesion that is able to metastasize quickly. Many of these individuals will remain asymptomatic, and others will have hematuria, lower back pain, palpable masses, depending on the stage of the cancer. There are different histological types that have been described for these cancers, but one thing that we need to remember, especially when providing counseling to the families, is that the penetrance for the renal cancer has been estimated in the past to be around 10 to 15 to even 19%. That meaning, if you put together 100 people with this pathogenic variant in the responsible gene, only around 15 to 20 are going to develop renal cancer. But it's so aggressive that needs an intensive surveillance. The last reference that we have is that some studies are saying now that indeed the penetrance is lower, so only 1.7 to 5.8% of people with some of these variants will develop finally the renal cancer. And the fourth characteristic of this disease is pheochromocytomas and paragangliomas. This manifestation is only associated with some specific variants that you can see here on the gene. So not all variants of the gene will produce pheochromocytomas and paragangliomas. Interestingly, in Quebec, in the French-Canadian founder families, we have two variants that are very frequent. One of them, the first one that you see here, is responsible for 60% of the cases that we see. And interestingly, none of these variants that we have in Quebec are associated with pheochromocytomas or paragangliomas. So this is not something that we are super concerned about for the French-Canadian individuals. In the cohort that have been seen during the last period at the Oncogenodermatology clinic, we have seen around 150 individuals, but in the group of the 130 affected individuals that have already been characterized from the molecular point of view, 88% of women have presented with uterine leiomyomas. 90% of individuals, male and females, have presented cutaneous leiomyomas. Only 5 individuals that we are aware of have presented renal cell cancer, which would suggest prevalence in our core of around 3.85%. 2 individuals had paragangliomas. Of course, these individuals do not have the French Canadian mutations, they have other mutations. And 2 very rare manifestations, but that we have also seen in our core. 2 individuals had skin leiomyosarcomas, and 1 individual had uterine leiomyosarcoma. So based on all this clinical observation, the team working at the Oncogenodermatology Clinic has proposed new clinical criteria for diagnosis this disease. So we have major criteria and minor criteria. If you have 1 major criteria or you have 2 minor criteria, then you should think that this person is affected by HLRCC. And the definitive diagnosis will be established when you find a pathogenic or likely pathogenic variant in the FH gene, and you prove that finally this is the individual is affected. Again, it's an autosomal dominant condition with a recurrence rate of 50%. Interestingly, this gene called FH, fumarate hydratase, when individuals, if a couple of 2 individuals who carry the disease match and have a descendant, there is 25% chances for an autosomal recessive disease that is called fumarate hydratase deficiency, which is very different to the one we are discussing today. So we are not going deep, but if you have questions, we can discuss more at the end. So how we estimate risk in these cases? As we said, any women in the general population has 70 to 80% chances of developing at least 1 uterine fibroid by day 50. If you have a first-degree relative affected with 1 uterine fibrome, then your chances will be duplicated to have these uterine fibroids. But if you are affected with hereditary leiomyomas and renal cell carcinoma syndrome, then your chances to have both uterine leiomyomas and cutaneous leiomyomas is around 90%. So in brief, most of these uterine fibroids that we see in the general population are caused, they happen sporadically. They happen around middle age, around 50 years of age, and most of them will be asymptomatic. If we compare that with HLRCC, it's very striking the difference because in HLRCC, they happen very early with average at 30 years of age, and they are very symptomatic, very painful, and needing interventions early in life. This is our last painting of the day. This is from 16th century. So the painting is called The Ugly Duchess. And what is interesting for any geneticist or any doctor in the room, there are very striking dysmorphic signs in this individual. But what I want to call your attention on is this individual has multiple small, round, pink color lesions in her face. And these are not pedunculated. These are not suggestive of other manifestations. So are these cutaneous leiomyomas? It's a big speculation, but if not cutaneous leiomyomas, at least when you see lesions like that, you have to keep in mind cutaneous leiomyoma, especially if you are in Quebec. And remember, beauty is only skin deep. So the last condition we are briefly discussing today is constitutional mismatch repair deficiency. So café au lait spots are very common. In fact, 10 to 28% of the general population have café au lait spots. We can have 1 or 2, and people call them brown birthmarks. So there are genetic diseases that anyone that is working in genetics knows about, and this is like neurofibromatosis type 1, McCune-Albright syndrome, Lesions syndrome, Noonan syndrome. But usually we see this café au lait as typical macules. So we call them typical because they will be clear, distant from the surrounding skin. They are easily seen on the ordinary light, and they have sharp margins. On the contrary, atypical café au lait spots are irregularly shaped. They have less distinctly pigmentation pattern, and they can have irregular margins. So if you look at this individual, you can see that there are multiple spots that are irregular with not clear. It's not similar to the common café au lait spot that anyone can call a birthmark. So we need to remember what is the mismatch repair to understand this disease. Remember that when the DNA is replicated, there are always mistakes that are going to happen. Like in this example, you see here we have an adenine when we should have a guanine, right? So there are proteins like MSH2, MSH6 that will recognize that there is a mistake in the replication of the DNA, and they will recruit other proteins like MLH1, PMS2, and together they are able to identify and repair this mistake. But what happens when this system is deficient, when you cannot repair the DNA damage? In that case, you will have, if you have one copy of one of these genes that is affected, then you will be affected by Lynch syndrome. And Lynch syndrome is very well known by many of us, right? So in Lynch syndrome, you will have one copy of the gene that is affected, and you are at risk for colon cancer, endometrial cancer, and some other cancers. Lynch syndrome doesn't present with café au lait spots, right? They can have skin lesions like the ones you see here, sebaceous adenomas, epitheliomas, carcinomas, or keratoacanthomas, but it's a condition that is autosomal dominant and has incomplete penetrance and variable specificity. So in the same family, you can see endometrial, ovarian, colorectal, pancreas cancer in different individuals. So what happens when an individual who has Lynch syndrome matches an individual who also has Lynch syndrome? Then there will be a risk of 25% that their descendants will have 2 copies of the affected gene instead of only 1 copy. When this individual inherits 2 copies of the affected gene, then they will have what we call the constitutional mismatch repair deficient syndrome. In this syndrome, it's a very rare genetic condition, usually presents in childhood, but many of the manifestations can present up to the age of 25 years. They have a skin phenotype that is similar to neurofibromatosis. They have café au lait spots, they can have axillary freckling, and they also develop multiple pilomatrixomas. What is sad about this condition is that there is a very broad spectrum of tumors, mainly T-cell non-Hodgkin lymphomas under the age of 18, high-grade gliomas under 25, colorectal cancer also under 25, colorectal adenomas, and any other link manifestation because they are affected with the 2 copies of the gene. This picture here represents a medulloblastoma in the child that I presented previously. So who are the individuals where we should suspect all these café au lait spots are not normal? We should refer them to genetics. I leave for you to review later here a table that makes a score system. Whenever you have more than 3 in that score, please refer these individuals. Of course, you will have this atypical café au lait spot, you will have early onset cancer, or you will have early onset manifestation of Lynch syndrome in individuals under 25, under 18 years of age. Very important to be aware of this condition because in Quebec, we have 2 founder variants, 2 founder mutations. In the Canadian Inuit population, there is one variant that is founded for PMS2 and another variant in the Quebec French Canadian. So already one case with this condition has been identified in the French Canadian population. So let's wrap up in general all this information that we have been discussing about cancer predisposition syndrome. If we put together in a pie all the individuals affected with some of these diseases, most of them will have sporadic forms of the disease. And this is what we call the general population risk. A group of around 10 to 20% has familial forms, that meaning that these 2 people in the family are having the same clinical manifestations. However, a very small percentage is the one who's going to be really affected by a cancer predisposition syndrome, and this is around 5 to 10% of the cases. In general, when should we suspect an inherited form of cancer, not only for skin, but for any organ? These are cancers that start at an early age. The individual can have multiple primary cancers. These are rare cancers like adrenocortical carcinomas, sarcomas, and there is usually a family history that is also positive for cancer. Remember that pedigrees are a very good diagnostic tool. So we always need to draw a pedigree at least 3 generations to find out about all these antecedents. We have to be interested also in the ancestry because knowing the ancestry, we know there are variants that will be more frequent in some populations. And of course, the presence or absence of consanguinity is also something to take into account. No matter what condition you are thinking on, no matter what cancer predisposition syndrome, please always refer the affected individual. This is the one that offers the best possibilities that we identify what is the variant that is affected the family. If there is more than one affected individual in the family, then send those who are younger at diagnosis or have bilateral disease or multiple primaries or other associated cancers. If you don't have any affected individual in the family, then sometimes we can do more. We can do tumor testing when this is pertinent. We can test a close relative that have another cancer that is potentially related to the disease, or consider unaffected relatives who don't have cancer but may have other criteria for some of these syndromes. And whenever you are in doubt, please refer to us. So where are you going to refer? We have this oncodermatology clinic, oncogenodermatology clinic that functions at the Montreal General Hospital. It's led by Dr. Elena Neshipuro, Dr. Fox, and with the collaboration of Dr. Shen and myself, and with the collaboration of urologists and gynecologists. But of course, we also have the medical genetics services, and I want to make a quick reference to all our colleagues who contribute always to the diagnosis of all these cancer predisposition syndrome, not only at here at the MUHC, but also at the UF General Hospital. And I can mention quickly Dr. Laura Russell, who has been doing clinics for genodermatosis for a long time, Dr. Fox and Dr. Anderson at the Jewish, together with 4 genetic counselors, because we team with genetic counselors who are excellent professionals who work very hard in diagnosing and managing these conditions. And also, apart from the general, we also have 3 genetic counselors here at MUHC that, together with Dr. Fox and myself, do these general cancer clinics, but also we have been developing specialized clinics in the last period. So not only the oncogenodermatology clinic, I have to mention also the excellent work Dr. Catherine Gaudi is doing with all the pediatric patients who are affected by some form of hereditary diseases, together with 3 genetic counselors, a nurse. And I would like to mention also Dr. Sogopoulos, who together with a genetic counselor makes an excellent work with pancreatic cancer surveillance, Dr. Kirchler, who works mainly on renal diseases and renal cancer. And we are starting a very new collaboration with our colleagues in endocrinology with Dr. Rivera to also offer services that are personalized to this core of patients. Take-home messages: many hereditary cancer predisposition syndromes present with characteristic cutaneous finding, and this feature enable timely referral and targeted genetic testing. Referral to genetics or to oncogenodermatology clinic is warranted when established criteria are met, ensuring coordinated dermatology genetics assessment and appropriate management. Accurate risk assessment for the affected individuals and their risk families is enhanced when we are able to identify the causal gene. So quickly, although you were almost correct at the beginning, let's review together the answers to the questions. So this individual who has more than 4 vasocellular carcinomas, what are the questions we should ask? So as many of you said, all of the above, right? We want to know if they do develop palmoplantar pits when they are exposed to water. We want to know if they have macrocephaly. We want to know if they have keratogenic cysts. For an individual who has melanomas, we want to know what of these cancers are present in the family. And again, the answer is all of them, right? Because pancreatic cancer would suggest CDKN2A association. A typical nevi increases very much their risk. And of course, multiple individuals in the family with melanoma suggest an inheritance pattern. If you have an individual who has multiple uterine fibroids, who has many symptoms related to that, the father had nephrectomy because he probably have kidney cancer, and they have cutaneous leiomyomas, then we are at risk for kidney cancer. And finally, if you have a child who is the product of a consanguineous marriage and develops all these atypical café au lait spots, what are the conditions that we have to take into account is specifically constitutional mismatch repair deficiency. So to end, I will say that we live in our skin. The skin remembers, so please make all your best to protect your skin from exposure to all these risk factors. And if we have time, I can take some questions.
Thank you so much for this wonderful overview of this really important topic. I see some questions in the chat. I'd like to just start perhaps with the chat, then we'll get to the room. Are African descent affected differently? How to screen lesions on dark skin, or is it a myth that African descent are less prone to skin cancer?
Well, it's not a myth because, in fact, what happened is melanocytes produce melanin, right? And melanin protects our cells against the effect of the ultraviolet light. So that meaning that if you have dark skin, in some way, you are more protected than someone who has fair skin. So it's not a myth, it's actually having fair skin is a big factor for developing all these skin lesions.
Fantastic. Are there any questions in the room? Yes, Dr. Fuchs.
Should I ask you from here?
Please come, yeah, or take that, yeah. Okay.
Tania, that was a very, very nice summary. I'm interested in the cutaneous leiomyosarcoma aspect. There's a recent publication that sequenced a truckload of these tumors and didn't find any FH mutations. So what's going on there then? What's the connection? What's the story? What's the missing piece? Do you know?
I don't know, but what I can tell you is when you have this condition with the FH deficiency, the chances to develop the skin leiomyosarcoma is very low. So we have seen it, but it's very unlikely that it happens in the disease. So I don't know the mechanism, but as many other tumors, not only leiomyosarcomas, this I would think is sporadic, unless this family had segregation of the disease. Was it an isolated cases or was?
Say again?
Was it an isolated case in the family or was?
Oh, they just sequenced.
Okay, and they don't find the.
They're super rare, so you would think that by chance, if there was an association, like if you sequenced a load of melanomas, you would find some CDKN2A mutations, right? You would find some.
You should.
It's just they didn't find any, so it kind of made me think that maybe there's something funny going on, but they're not really.
I don't have explanation.
Yeah.
So just coming back to the cancer and the cutaneous associations, do you get referrals that come from cancer looking for cutaneous, or do your referrals all come from cutaneous and then they look for cancers? Just get a sense.
I would say both.
Both.
I mean, let's say if an individual has Lynch syndrome and they know they are at risk for sebaceous adenocarcinomas, then they are referred to the OGD clinic and we do follow-up, a regular follow-up to see if they develop this lesion or not. Same thing if you are referred because you have uterine leiomyomas, which are FH deficient, and you are suspected of having HLRCC. Anyways, we are going to perform physical exam of the skin because we know that cutaneous leiomyomas are a very good predictor of the disease, and that will help understand if the disease is present or not. So I would say it goes both ways.
Mark?
Thanks very much for the presentation and an art history angle as well. Nice. Just very, very specifically, what once you've identified these syndromes, you sort of flashed surveillance as something that's done. But are there specific recommendations for surveillance with each of these syndromes, and sort of what's the follow-up of these patients, just to get a sense?
Yeah, thank you for that excellent question. Yes, so depending on what is the condition we are talking about, and sometimes even what is the variant in the gene that we are talking about, there will be a target and personalized surveillance. I can give you different examples. For example, in Lynch syndrome, we do surveillance for endometrial cancer. Sometimes we offer the option to do hysterectomy, which is prevented to don't develop this cancer. The most important risk is for colorectal cancer, so we will be doing colonoscopies. And for the skin, we will be doing surveillance every 1 or 2 years at the OGD clinic to see if they develop the sebaceous carcinomas. But for example, in the case of the constitutional hematocrit deficiency, which can start very early, we have this excellent clinic led, as I mentioned before, by Dr. Gaudi, where patients will be having follow-up for every one of these potential manifestations. And with a regularly schedule, we are all the time monitoring the possible presence of one of these manifestations. So yes, we do surveillance, and that's the importance of knowing what is the variant in the family, so we can do predictive testing in all the possible members that are not still affected but are at risk. So they are also put in the protocol for surveillance very early, but it will be personalized and targeted to the variant, the gene, and the condition in the family.
Just a quick question from Dr. Fantis. Do you think that the rate of familial cancers are we underestimating this? Should we be referring more patients, in your opinion?
The issue is that, as we said, the risk is there, and probably we are underestimated individuals who are at risk. The issue with this cancer predisposition syndrome is that there is reduced penetrance, and it's a phenomenon that is common to all these syndromes. That meaning it is not enough that you carry the familial variant to develop the cancer. You need a trigger, you need exposure to this environmental factor that sometimes we are not able to identify, so you can develop the cancer. But yes, for sure, many of them are. A good example for that would be hereditary leiomyomatosis. We thought in the past it was a rare condition. Having one individual affected in 1,000, that means we have people who are affected at the MUHC, because by frequency, we should have some of them here. What happened is, as the cancer has low penetrance, only 5 to 15% will develop renal cancer. People who have cutaneous leiomyomas, they just don't care because it's a benign lesion. They sometimes never get attention about that. And on the other hand, women with uterine fibroids, we say, okay, this is common, so it can happen to anyone. So that's why it's important to raise awareness about these subtle differences in these syndromes, so we can receive your referrals, and we will be very happy to take all of them.
Yes, so the last question.
So when you say that an individual has the familial form of the cancer, does that mean that they don't necessarily have like a pathogenic variant in that specific gene, but they might still have a hereditary predisposition by having variants in other genes with smaller subsets, or is it just shared environment?
That's an excellent question. Thank you very much for asking. Yeah, so the question is, these individuals that we call familial cancer, but the question is because they don't have a gene that is responsible for producing this risk, or is the addition of small effects? And yes, we think it's a very vast discussion around that, right? And I know Dr. Foss doesn't like at all the classification when we say sporadic, familial, and monogenic, but it's a way we use to show you and to make you understand that having a familial form, the only thing is telling me 2 or more people in the family are having this cancer. But why is this happening? Number one, sometimes we are exposed to environmental factors since we are children. So when you're a child, you are taken by your family to the beach and everyone is under the sun. So you will develop the melanoma when you are an adult, but you had exposure very early in time. So it's difficult now to make the connection. You're not exposed to sun now. That's one thing. The other thing is, we all have SNP, so we have single nucleotide polymorphisms here and there, and they don't represent a pathogenic variant itself as a major predisposition gene. But if we make the addition of all these small effects, and is what we understand now as polygenic risk scores, the final addition of these small variations that we have at the end can produce an increased risk. And then, of course, you need the environmental factors. So we don't think these are major predisposition genes. As example that Dr. Fox mentioned, sometimes we don't find explanation, we don't find a major gene. We see them today as the interaction between these small genetic factors associated with environmental factor. But easily, any of you can prove me wrong in some time, because we are learning and advancing. So hopefully we will know more in the future.
Thank you. Thank you so much, really, for the terrific presentation. You certainly did raise awareness. Some of us may leave a little bit paranoid today, but thank you. I appreciate that. And thank you for the art lesson. We'll certainly look at some of this Rembrandt art a little differently. I wish everyone a great afternoon. Thanks for joining us for Grand Rounds today.